Good evening, everyone. Today is our first class, and it is on prostate pathology. As I've already given the reading material to everyone, please mute yourselves, everyone. I do not want any disturbance in between the class because it distracts the other people also. So, whenever you join, mute yourselves. Is my voice clear now? Am I audible to everyone? Dr. Mayuri, can you tell me if I'm audible?
Yes, ma'am.
Great. Right. So take one more minute and maybe a few seconds, and then we'll start. Please mute yourselves, everyone. Okay, from next time, please join with your names and the names that have been registered with us, one profile only. And from next time, if anyone is joining without their registered name, I will not be able to let them in. So so no short forms as well, DSDD or MB or anything like that. So just your registered names, the names with which you have registered with us. All right. I hope that is clear and very easy also to do. Also, the moment you join in, please make sure that you are muted and you only unmute yourself when you are asked a question and you are asked to unmute. Okay. So these are a few rules which everyone, if they'll comply, you'll basically have very smooth classes without any disturbance. So today's class is on prostate pathology, and I'll start with the screen sharing. And I hope everyone can see it clearly. It's visible. So we'll start with a normal anatomy of prostate. I'm sure you all have already read a little bit about it because it was told to you beforehand, and you know, there were a lot of articles that were given to you, which are really beneficial. If you go through them, they will basically tell you each and everything that you need to know about the prostate pathology. So okay, so here we have the bladder, and this is the prostate sitting right here. Beneath the bladder and above here, you will find something which is called as a urogenital diaphragm. Okay, so the base, it's like a funnel shaped organ in which the base of the prostate is at the top and the apex is at the bottom. Okay, so the apex basically lies just above the urogenital diaphragm. Why I'm telling you this is because this anatomy tells you a lot about what pathology it could be based on the location of the disease. So anything, if a section is taken from the apex, what you should be looking at and what you should basically ignore. So all of these things are important when you are dealing with the prostate, and that is why you need to know what is the base, what is the apex, what is the anterior fibromuscular stroma, and then you have the posterior zone. So posterior zone, or the which we usually call as the peripheral zone, is not just the posterior lobe. All right, so there is difference. We are not talking about lobes here. What I'm telling you about is just the zones. So there is prostatic urethra. All right, that prostatic urethra, just imagine the area around it. Okay, that is your transition zone or the central zone. So you can you know, roughly you can say that, you know, for your convenience, basically we can divide it into just two. Okay, so number one is the transition zone, that is the periurethral zone, the area that is just around the urethra, where you usually get the BPH lesions. Okay, so your benign prostatic hyperplasia is usually located in the central or the periurethral zone. Or and we have the peripheral zone, which is, the most of the posterior lobe is occupied by the peripheral zone, but it is not restricted to it. The peripheral zone also extends up to the apex and to the base. But the entire thing, the entire posterior, the entire uh, pocket is involved by the peripheral zone, and that is the zone where you find the carcinomas. All right, so the peripheral zone is the one where you have to look for carcinomas. Now, what is the importance of anterior fibromuscular stroma? Anterior fibromuscular stroma along with the apex, that is somewhere here, right? This is the anterior fibromuscular stroma and the apex. This is the position where if you take a section from here, you will see the skeletal muscle fibers of the urogenital diaphragm basically, and engulfing the engulfing the benign prostatic glands, which may appear like extra prostatic extension. It may look like that the glands are invading into the surrounding muscle, and sometimes that is why confused with a extra prostatic extension. However, you should note that any such extension into the skeletal muscle, especially at the anterior section, anterior and the apex section, is not to be considered. All right, so just look at those glands. These are usually benign glands. So that is all about the importance of these anatomical spaces. So we have the peripheral zone that is more likely to have prostatic carcinomas, and that is why when you do a digital rectal examination, you will be able to feel these nodules which are there in the peripheral zone easily, right? Whereas if it's a BPH, it's more likely to present with symptoms of urinary symptoms, basically of retention, etc. Right? So because it compresses on the urethra first, and the peripheral zone basically will be somewhere outside in the periphery, and that's why on DRE you will be able to feel it in a better way. Now, that is your anatomy. Let's look a little bit about the histology. So this is the normal histology of the prostate. So, when we are talking about any glands, whenever we talk not about prostate, in any other areas, whenever there are papillary enfoldings and, a lot of irregularly shaped glands, we usually consider it a query. It's like a question, oh my god, is this malignant or is this abnormal? But for prostate, it is the most normal that it can be. So if you see irregular type of glands and not really forming particular round and round spaces and have those very straightened luminal borders, instead they have these kind of papillary enfoldings and ruffled borders inside the lumen. These are the ones that are normal. Okay, so a lot of mucin in the glands and a very benign looking glands, very normal looking nuclei. And now, so the first thing that you note on low power examination is the architecture. Okay, what are you looking at? So these glands are usually present embedded in the fibromuscular stroma. All right, so you'll have a lot of fibromuscular stroma, and then these normal benign glands of prostate will be just sitting there in the forming clusters, and usually forming clusters and lobules, and they will have these kind of not irregular or not infiltrative. They are very, very round and very, very regular, but they are not very uniformly shaped. So just look at this as in as here. It's not a uniform round gland, isn't it? It's a very irregularly shaped, but also with regular sort of regular boundary, as in that the margins are not infiltrative, right? You can't see them forming those very, very angulated edges and going inside, infiltrating into the stroma. It's not like that. You can see that these are, when you look at them, they are very, very regular and smooth edges but at the same time, they are not very round and not very, you know, good looking. They are of very variable say shapes and sizes, and very benign looking glands filled with mucin. Mostly they will have a lot of secretions inside, some secretions that we call as corpora amylacea, which are just which have very characteristic appearance, you should see. And ruffled borders, papillary enfolding, so all of that is normal for the prostate gland. Now, something that you see on the edges like this, these are basically the quiescent alveoli or quiescent acini of the prostate. And these are just developing basically, and that is why they look like this. Excuse me. So this is what corpora amylacea is basically. So these are the same secretions in the prostate acini, which have sort of, got lamellated over time. So that is your corpora amylacea. It is usually seen in benign glands. However, it's not that if it's seen in a gland, you can call it benign only. So these kind of secretions can be there in malignant glands as well, but usually it's a sign of benignity. Look at these glands here now. They're so bad looking. Like, had they been present anywhere else in the body, you would have said that, oh, this is not normal. This is, at least some hypoplasia or something like that. But this is absolutely normal for the prostate. So these kind of papillary enfoldings, so normal, so nicely, normal. So you see these on the low power and you feel, all right, this is just something that you can skip. You don't even go to the high power for these glands most of the time. Okay, so so today we will start directly with prostate adenocarcinoma. I am not going to cover BPH because BPH is basically benign glands present in greater proportion or something like that. So in which there is hypoplasia of the prostatic glands and as well as the stroma. So that is what BPH is basically, and there's no point going over it. Again, what we'll talk about is prostate adenocarcinoma, and that is the most important lesion that you should be knowing. So one of the most common malignancy in men in developed nations, and even in India, it's very, very common, very commonly found prostate adenocarcinoma. So what are the factors that lead to prostate adenocarcinoma? Number one is being a male. Itself is a risk factor for prostate carcinoma. So every male is at risk for prostate carcinoma. So, androgens, which are there in males, and what can protect you is castration before puberty. So obviously, not something that anyone would opt for. Other than that, anything extra that puts people at risk is hyperestrogenism. So, for example, patients with liver cirrhosis. So they have these have appears to have low incidence. So they have kind of protective effects. Okay, so androgens, a negative effect or a risk factor, and hyperestrogenism is the protective factor. So anything, so estrogen and androgens going opposing each other basically. Then other than that, there is not really a risk factor, but BPH, as was sometimes thought that could be a risk factor, but it is not. It's usually a coincidental finding seen along with prostate adenocarcinoma. Sometimes you get QRP specimens for BPH and you find incidentally find adenocarcinoma in that. And we'll talk about what we call those carcinomas that we find incidentally on a TURP specimen done for BPH. Okay, and other than that, you have PIN, that is prostatic intraepithelial neoplasia. That's a precursor lesion for prostate adenocarcinoma, and PIN is low grade and a high grade, and we'll be talking about that also in a few minutes. So what is the clinical diagnosis? How you diagnose? So there is a triad. Number one, digital rectal examination, transrectal ultrasound, and serum PSA levels. Out of these, the serum PSA levels are very good marker, not really very, very high sensitivity or specificity, because they can be seen elevated in BPH as well, or following a DRE examination, if you do a PSA level, they will be high, etc. Transrectal ultrasound again can detect lesions as small as 5 millimeter, and but majority of these lesions or many of these lesions are isoechoic. That means that their texture is just like the texture of the other normal appearing gland, and that is why you're not able to check that on USG. So nowadays what people are doing is relying on transrectal ultrasound guided biopsies. So usually when PSA levels are high in a patient uh, who is possibly having a lesion, or just investigation for high PSA levels in the absence of BPH, or when the PSA levels do not correlate with the volume of the prostate that you see on ultrasound. In that case, sometimes they undergo prostatic core biopsies, and that is the thing that is being done right now these days. So the incidence, or the basically what you say, the tendency for the clinicians to go for a transrectal ultrasound or a DRE has kind of reduced, and serum PSA levels is something that everyone is mostly relying on these days. And you do that, you check for the volume, and for a given volume, if the serum PSA levels appears high, that is in the absence of BPH. If the serum PSA levels are higher, you basically think of could it be carcinoma, and in that case usually they opt for prostatic core biopsies. These core biopsies are taken from each of the areas of the prostate gland. So the entire prostate gland is divided into 12 to 14 areas, and in that 12 to 14 areas, every area is taken. So around 12 to 14 core biopsies are taken. I'm sorry, am I not clear, or are you having audio issues? Because some of the people are complaining of the audio issues. Dr. Asma? Yes, great. Okay, so majority of the people have no issues, as I can see. So for those who are having any issues, kindly check your internet connections. There might be, some slow internet issues at your end. So anyways, let's continue. So PSA levels have a gram for gram relationship with prostate mass. So mild elevations can be seen in BPH, but levels above 4 milligram per milliliter, you require serial measurements and performance of a biopsy if levels continue to rise. Almost half of the patients of carcinoma have levels more than 10 milligrams per milliliter. So more than 10 milligrams per milliliter levels, you should go for a biopsy. So what are the two major categories of prostatic adenocarcinomas? Number one is the adenocarcinoma of the peripheral ducts and acini. So, just like any other, please mute yourselves, everyone. I can hear some disturbance. Dr. Amar? Yes, thank you so much. So, so this is the peripheral ducts and acini, adenocarcinoma of the acini and peripheral ducts, and the adenocarcinoma of the large and primary ducts. So obviously, the one with the acini and the peripheral ducts are the most common and majority of the lesions, and the large primary duct adenocarcinoma is sort of rare. So let's look at the gross of the most common form of adenocarcinoma. So it is, look at this here. It's one, it's in the periphery, right? It's in the peripheral zone. It is yellowish or gray in color, poorly delineated. So it does not have well circumscribed edges. These are usually firm areas, and that's why when you do a DRE, you can feel these areas very nicely from the surrounding gland. Now, there is something called as a vanishing cancer syndrome, and that is that if so very little of this tumor was present, and the entire tumor has been resected during the biopsy, and so when it comes positive on biopsy and you do a resection of the prostate, you do not find any carcinoma because the entire carcinoma has already been taken out in the biopsy, and that is what we call vanishing cancer syndrome. So microscopically, there are four major cytoarchitectural patterns. Number one is medium-sized glands. Number two, small-sized glands. Number three, diffuse individual cell infiltration. And number four, cribriform patterns. So these are the four major cytoarchitectural patterns Now, this is there for your knowledge, but whenever we are doing a prostatic adenocarcinoma, you have to know that, the moment you say and see that this is adenocarcinoma, the next question that comes in the mind is, what is the Gleason score? Okay, so prostate carcinoma, Gleason score go hand in hand. So you have to, if you're calling something a carcinoma, you have to give a Gleason score. And we will see in our next class, you can write it down, the question, in what cases Gleason score is not given. All right, so in what cases of a prostate carcinoma, Gleason scoring is not done? So that is an important question for you all. And so yes, so Gleason score is basically a number that is given to these patterns, depending on what pattern it is and what we see, and that is dependent on the differentiation of the glandular cells that are present. And so it starts from a score of 1 to 5. So every pattern is given a score of 1 to 5. And usually when you have resected specimens, the two scores that you choose are of the two most common patterns. Now this is again an important thing coming up, so please pay attention. Two most important or most common patterns. Okay, so if it's a pattern 3 and 4, the most common pattern, the first most common pattern is 3. The second most common pattern is 4. You give it a score of 3 plus 4 is equal to 7. Okay, and it is important that it's 3 plus 4 and not 4 plus 3, because that will change the grading system now. So in the most recent updation of this, basically they have changed the grading system. It's not the same as Gleason score 7. So Gleason score 7 is divided into 3 plus 4 and 4 plus 3, and that changes the Gleason grade. Okay, and we will talk about that in the coming slides as well. So what is Gleason score 1 and 2, 3, 4, 5 basically? So Gleason score 1 is 1 and 2 basically are very, very theoretical. We usually do not do that because nowadays what you get is basically biopsy specimens. So you get core biopsies or you get TURP. And for 1 and 2, basically, please pay attention, for Gleason score 1 and Gleason score 2, you need circumscribed nodules of the tumor. So this is a tumor that is very well circumscribed. It is microscopic. It is very well circumscribed. Gleason score 1 will have an absolutely well circumscribed tumor, tumor nodule, which consists of a singly placed glands which are separate from each other and which have intervening stroma. These are very tightly packed and are uniformly packed. So uniformly packed, tightly packed glands that have intervening stroma, and they are present in a nodule, a well circumscribed nodule. You can maybe picture it in your mind as an adenoma. Okay, so obviously it's not an adenoma, it's a carcinoma, but just to make a mental picture of what it looks like, it's like a well circumscribed area which consists of a very, very well differentiated area of glands that are uniformly packed. So they are almost equal in size and shape, and also present equal at equidistance from each other. So that is what I mean when I say uniform appearance. Okay, so that is your Gleason score 1. Now that you can find only in resected specimens, isn't it? To find it on a biopsy usually is not possible, because usually they're not that microscopic. Also, they'll be they'll have a dimension to it, and when you do a biopsy, you will most likely pick up only a part of it and name it as Gleason score 3, right? Because you are not able to identify it as a nodule per se, right? You do not know whether it is infiltrating into the stroma or not, whether the stroma that you see is from the nodule or from the surrounding tissue. So you cannot do 1 and 2 score on a biopsy. All right, so that is one. What is Gleason score 2 is when at the edges you see minimal invasion. So imagine that nodule that we were talking about, and see that neoplastic glands have minimally invaded into the surrounding non-neoplastic tissue. Plus, the glands are not packed very, very uniformly. However, they are still single and separate. You can identify them as single glands, and they are still separate. They're slightly loosely packed, and so that is something that you see in Gleason score 2. So that is just for theoretical point of view. And what you usually see, the most common pattern that you see is Gleason score 3. And Gleason score 3 is basically where you find very nicely packed, very nicely formed glands. So these are small to medium-sized glands, okay? And these glands are found separate from each other. Look at the screen. Separate from each other. There is intervening stroma in between. And these glands are infiltrating into the the surrounding tissue. So there could be desmoplasia around these glands. They have infiltrative margins. So for example, if you see this picture here, all right, so we do not have a low power picture here, but all right, so you just have to imagine basically, right. So basically, these are small glands that are infiltrating into the stroma, and you can see benign non-neoplastic tissue around, and these neoplastic glands are present. You can still make them out as properly formed glands. They are not fusing with each other. They are not forming any sort of patterns. They are very nicely small or medium-sized glands, and they are present. What you will have to make sure here is that there is no basal cell layer. So now let me go back to the first slide and tell you that basically we have 3 cells in the acini. Number 1 are these secretory cells or the acinar cells. Number 2 are the basal cells, and these are the ones which have the cigar-shaped sort of spindly nucleus. And this is present in between the acinar cells or the luminal cells and the basement membrane. So the basement membrane surrounds these basal cells. This is for theoretical knowledge because obviously you cannot see basement membrane here. But yes, so basal cells are these spindle cells or the cigar-shaped nuclei that you see here, and these are the acinar cells. And then there is the third type of cell that is usually seen only on special stains and IHCs, and that is the neuroendocrine cells. So these are variably present in various acini. So what we were talking about here was that this gland, which is a neoplastic gland, will not have the basal cell layer. Okay, so the basal cell layer will be absent. Now, what are markers that we use? So just for, we'll be talking about IHC later on, but just to sort of, bring it up here, that these are the cells that can be stained by 2 stains, basically. Cytologically, they consist of what you say as high molecular weight cytokeratin. So high molecular weight cytokeratin is the cytoplasmic stain that stains these basal cells, and P63 is the nuclear stain that stains the basal cell nuclei. Okay, so note on these 2 stains, very, very important again. And obviously the other cells are stained by PSA and a lot of other markers that are there. And also when you do it for carcinoma purpose, AMACR, that is AMACR, is also used to stain the neoplastic cells. So it will be positive in the neoplastic cells. So that is about the cells and how you'll see it. So that was the Gleason pattern 3. Now Gleason pattern 4 is basically when you have, the glands are not very, very distinct from each other, and they're kind of fusing with each other, and they have some architectural patterns like cribriform pattern, glomeruloid pattern. And so this is the cribriform pattern here. So this is your, the Gleason pattern 4 basically is the cribriform pattern. So those are the patterns that you see in the Gleason score 4. and that is less differentiation. So 1, 2, 3, 4, 5, and the differentiation is going down, right? In Gleason score 5, you see diffuse cell infiltration. Okay, so the diffuse cell infiltration, single cell infiltration is basically your Gleason pattern 5. And so this is the way how you do the scoring. So you'll basically do if you have, so yes, I was talking to you about the resected specimens. You will give a Gleason score of the first and the second most common patterns. Now, the highlight here is that on biopsy specimens, the two Gleason scores that you do is the most common pattern and the highest grade pattern. So the most common pattern comes first, and then you basically look at the highest grade pattern. Now that is the difference. On resected specimen, first most common pattern plus second most common pattern. On biopsy specimen, first most common pattern plus the highest grade pattern. Because on a biopsy specimen, when you have just limited amount of tissue, you do not want to ignore the highest grade pattern that you are looking at. So obviously, maybe further on the resection, you may find that highest grade pattern was maybe only say 1% of the entire tumor tissue, and your Gleason score may come down from say a score of 3 plus 5, it may come down to 3 plus 4, right? But on biopsy, you cannot ignore a grade 5 pattern or the highest grade pattern, right? So that is the importance of this differentiation, and that is again something that is very commonly asked in exams as well. So this is just to say medium-sized glands. These are closely packed glands with irregular outlines, smooth inner surface. So yes, the inner surface or the luminal surface here will become smoothened. Okay, so it will basically smooth out. So there is no papillary enfolding, there are no ruffled borders, and nothing of that sort in the neoplastic glands. So that is very important. And there is very scanty intervening stroma. So these glands, these may be separate out. They are single, and you can note them out as make them out as single glands, but they will have a very small amount of intervening stroma. They're very tightly packed, and you look at them like neoplastic glands. So similarly here, just look at these are the small size glands. Again, look at the borders, the luminal borders, very round and very straight. There is no problem there. Here you can make out nuclear features, very prominent. You do not see these kind of nuclear features on a prostate biopsy. Prostate cells are very bland cells. Normally, prostate cells are very bland. Even in majority of the carcinomas, you will not see, highly abnormal nuclei. So psychologically, sometimes when you see these nuclei, they can be enlarged, they will be irregular, there'll be hyperchromasia or prominent nucleoli. So prominent nucleoli are macronucleoli more than 1 micron in size, and they can be multiple also. Mitoses are very rarely found in well-differentiated carcinomas. Okay, so nuclear features are not very, not very consistent of a prostate carcinoma. So, you can have prostate carcinoma, well-differentiated carcinoma without the nuclear features. But nevertheless, nuclear features, for example, here, just look at the nuclear features. I mean, are you able to see a nucleoli in any of them? Yeah, maybe here, but really not too much. So what you basically do also on low power is try to look at the glands and compare them with the benign glands. Okay, so there are obviously benign glands present which have those papillary rufflings and those benign features. So just compare the glands that look suspicious to you to the benign glands, and they will show some sort of differences. So the cytoplasm may be more eosinophilic. There'll be less of that mucinous appearance in the cytoplasm, and the nuclei will appear slightly bigger, if not much. So if you see only the malignant glands, you may not be able to see that difference. But if you compare the two, compare the benign with the malignant, you'll be able to see the difference that is there. That is nuclear enlargement, irregular nuclei, etc. So these are the features that you see of the uh, glands, nuclear features. Now this is this diffuse cell infiltration. Now this is just look here. There is no pattern to the cells, right? They're just diffusely infiltrating, right? Here, these are the benign glands, and you can see that these are large and benign glands with papillary enfoldings and ruffled borders. Here, the entire thing is showing there are mitotic figures. Again, you cannot see that the nuclei, maybe some of the nuclei are hyperchromatic, but you know, those nucleoli and enlarged nuclei, etc., you can't make out. But yes, these are abnormal looking nuclei, and these are cells that are showing diffuse infiltration. They're not forming glands, they're not forming any architecture, they're not forming any sort of pattern to it. So this is diffuse cell infiltration. This is Gleason's score 5. Now this is something what also single cell infiltration looks like, and this resembles the invasive lobular carcinoma of the breast. So if this picture is basically, you know, if I tell you that this is from prostate, it is of prostate carcinoma, Gleason score 5, and if it is from breast, it is invasive lobular carcinoma of the breast. So you know, you can use this picture in any of the ways. Basically, there is that much similarity that no one will question. A breast pathologist cannot say that this is not from breast and it's from prostate. All right. Obviously, without the IHC stains. So next is the cribriform pattern. So this is the cribriform pattern. And what is introductive carcinoma? Okay, I'll be talking about introductive carcinoma in a few slides. And so this is what basically a cribriform architecture looks like, where the glands are fused and there is no, you know, there is no stroma in between the two gland layers, in between the two layers of cells. For example, this is a cell layer and this is a cell layer, and there is no intervening stroma. So that means either a fused gland. Obviously, these are so many glands fused together will become like a cribriform gland. This is the glomeruloid pattern that again is Gleason score 4, and this is intraluminal ball-like clusters of tumor cells, and this is could be said that it is pathognomonic of malignancy. Okay, so this is a case, 72-year-old male with elevated PSA, prostate needle core biopsy obtained, and you see these kind of ducts here, and this is the picture basically. So anyone wants to volunteer on what do you think is the carcinoma? I don't want the, okay, all right, anyone?
Ma'am, there is basal nuclei I've seen, ma'am. So I don't think it's a malignancy.
May I know your name? Just speak out your name first and then go on with the answer.
Sindura.
Sindura, yes, tell me. What do you think? Yes, Dr. Sindura, what do you think?
Like, ma'am, there are single cells are seen which are infiltrating into the stroma, ma'am. These glands, which are some fused glands are seen, but surrounding those glands, there are basal cells are seen, ma'am. Okay. Whereas adjacent to the normal gland, some infiltrating cells are seen. Infiltrating cells into the stroma is seen, ma'am.
All right, great. Yeah. So do you want an IHC for the same? So this is the IHC. As you said, that these are lined by the basal cells. So this is the basal cell markers, the PC marker.
Okay, ma'am.
So yes, you were right. So these are lined by basal cells, and these are the abnormal cells or diffuse cell infiltration pattern. And this is what we call as the intraductal carcinoma. Okay, so this is the intraductal carcinoma. Now this is what we are, the new term that I'm introducing you to basically, and we'll be talking in details about it in the next class. But let us see a little bit about it. So this is again also intraductal carcinoma. Here you do not see any other thing. But what is, so what for malignancy, you have to see that there are malignant cells and the glands are not lined by a basal cell layer. So that is your prostatic adenocarcinoma. right? Now, we are talking about the carcinoma of the peripheral ducts and the acini. These are not from any angle looking like peripheral ducts or acini. They are much larger in size. So they are very, very large appearing ducts, and they are lined by these neoplastic cells. So here the diagnosis is intraocular carcinoma for this, as well as for these glands here. Obviously, this is also comprising of this component of adenocarcinoma of diffuse type. Now here, malignant epithelial cells filling large acini and prostatic ducts with preservation of basal cells, along with number one, solid or dense cribriform pattern that we saw. Here, this is a solid or dense cribriform pattern. This is, the entire lumen is expanded by the cells. More than 50% of the lumen is expanded by the cells. It is, formed by more than 50% of the lumen. Then loose cribriform or micropapillary pattern that we see here. This is the micropapillary pattern in which you see these micropapillary excrescences here. And then you have, other than these two, you need to have marked nuclear atypia, that is nucleus size of more than 6 times the size of the normal nucleus. So that is very, very prominently large nucleus. And non-focal comedonecrosis. So if they have comedonecrosis and not just at one foci, so non-focal comedonecrosis that is present in many foci of comedonecrosis, that these are the basically features to diagnose intraductal carcinoma. So by definition, intraductal carcinoma is not invasive in itself. It is what is intraductal carcinoma basically? So when we have a tumor that is very, very malignant, highly invasive. Usually 50% of these tumors are high grade Gleason score 5 tumors that are there, and they find their ways into the large ducts. Okay, so from the smaller acini, they have reached the large ducts. Okay, and now in the large duct, they are expanding the ducts. They are present, so they are not, obviously, they are not the ducts that are malignant. These are the cells that have filled the malignant, these are the malignant cells that have filled the ducts. And when you do a cross section, you see that the ducts are normal. They are lined by the basal cell layer, but they are filled with these malignant cells which have necrosis. Comedonecrosis is something in which you'll see that a lumen has necrosis, and it is lined, the duct is lined by highly malignant cells, so with a center of necrosis. Okay, so that is comedonecrosis. And so basically that you'll see. And so yeah, so that is not, by definition, not invasive carcinoma. If you see that, although it gives you a hint that there is an invasive carcinoma nearby. Okay, so that is the importance of finding intraductal carcinoma, that if you found it and you in the same sections you do not have carcinoma, you do not have prostatic adenocarcinoma, look for prostatic adenocarcinoma. Go ahead and find other areas, look for other areas, take more sections and look for an adenocarcinoma, because there are high chances, very, very, very high probability that these lesions will be accompanied by high grade, not just low grade, not just adenocarcinoma, but a high grade, high score adenocarcinoma with more than 50% of the cases having a Gleason pattern 5. So that is the importance of having intraductal carcinoma. Now, what are the diagnostic criteria for this? These are large caliber glands. These are, I'll be talking about the pin thing later on. These are large caliber glands that are more than twice the diameter of the normal peripheral zone glands. So normal peripheral zone glands that we have seen throughout, and we have described the entire Gleason pattern score on that. And so these are the glands that are almost twice the size of those glands. And they have preserved basal cell layer, because as I said, the glands, they themselves are not malignant. They are just filled with malignant cells. Cytologically, the cells that are filling the glands from inside are malignant. To what extent are they malignant? So either they will have new comedonecrosis, or they will have cribriform architecture, densely packed cribriform architecture, or loosely packed cribriform architecture, or nuclei more than 6 times the size of the normal nucleus. Expansile cell mass that spans the glandular lumen. So the entire lumen is filled with the cell. And then there is central comedonecrosis. Ducts will have, which are lined by these malignant cells, will have necrosis in the center, so that is central comedonecrosis. So these are the 5 major criteria. And then there are a few minor criteria, not very, very important. This is a diagnostic approach, basically. So what you see these prostatic glands with lumen spanning cytologically malignant secretory cells. So the entire lumen is filled with these secretory cells. Are basal cells present? If there are no basal cells in these ducts, obviously it will become an invasive carcinoma and your headache is less now, So then if the basal cells are present, you do a P63 stain and the basal cells are there, then you would ask yourself, is it a solid or dense cribriform pattern? If yes, it's intraductal carcinoma of the prostate. If no, you look at the nuclei. Are the nuclei more than 6 times the size of the normal nuclei? Yes. All right, it is intraductal carcinoma. No. Is there any non-focal comedonecrosis? Non-focal again, proper comedonecrosis in majority of the glands. Yes, again becomes an intraductal carcinoma of the prostate. Here again, if it is no, then this is just an atypical intraductal proliferation where you cannot exclude intraductal carcinoma of the prostate. So here again, this just means that by histopathology, by the size of the gland and the presence of malignant cells, you can say that this is an atypical intraductal proliferation, but you cannot exclude an intraductal carcinoma of the prostate. Now, why go through such a headache to find out intraductal carcinoma? I've already answered the question, because it is accompanied by a very, very high grade malignancy. Okay, so this is what I have told you, that this is aggressive disease, high Gleason score, extra tumor volume, there is extra prostatic extension. So if it's going into the large ducts, it's already probably also gone outside the prostate. Positive surgical margins is usually seen in these cases, and rapid progressive disease. This is basically whenever you see on histopathology something that is looking like intraductal carcinoma of the prostate, you have to differentiate it from high grade PIN. Okay, so high grade PIN basically is the precursor lesion for malignancy, and you can imagine why you have to differentiate between the two. One is a precursor and the other one is sort of a post-cursor, if you can name it like that. Basically, it's like PIN is before the tumor starts, and IDC is after the tumor starts proliferating and progressing, and now it has reached the prostatic ducts, the large ducts. So it is more of a spreading stage. So that is why you need to identify, whether it is one or the other. So these are very, very important points that are written. So in HGPI and IDC, in both the lesions, the basal cells are present. Okay, that is the main confusing factor. The basal cells are present. Is it a high-grade PIN or an IDC? Now, in a high-grade PIN, you will not see cribriform pattern most of the time. So very rarely will you see fully distended ducts. More than 50% of the ducts are distended by these malignant cells and having that cribriform pattern. So cribriform pattern, first thing, goes in favor of an IDCP. Then again, usually in a high grade PIN, you have very uniform nuclear atypia. So the nuclei will show, obviously it's a high grade PIN you're calling it, but the atypia that you see is very uniform. All the cells will show similar type of features. Whereas in IDC, just imagine that these are the cells which are highly aggressive and very, very bad. Even among the neoplastic cells, these are the ones which are bad category of neoplastic cells. So these show marked nuclear pleomorphism, not uniform nuclear atypia. Again, there is no necrosis that is seen in PIN, and there is non-focal comedonecrosis that is usually seen with IDC. Okay, so so this is a minor criteria and very difficult to identify tumor cell populations, but usually the high-grade PIN will have similar looking cells, and the IDC will have two populations, usually central population and the peripheral population. Then you have, yes, the mutations. The mutation, it is important from the exam point of view. Please note down this: no ERG mutations are seen in high-grade PIN, whereas IDC and as well as the carcinomas will show ERG mutations. So ERG mutations are present in intraductal carcinoma as well as in the malignant lesions. Cytoplasmic retainment of PTEN is seen in high-grade PIN, and cytoplasmic loss of PTEN is seen in IDC. So these are a few differences between the two. We'll be talking more in depth about PIN, especially high-grade PIN, tomorrow in our class. And so this is ERG stain done. So similar expression is seen in both intraductal carcinoma and invasive carcinoma. This is ERG positive on the left side. You can see that you know, all the tumor cells are showing positivity for ERG, and here, which is you know, ERG negative, so there is no positivity here. Okay, so I think we should continue in the next class now. It's already been all right. Maybe I should cover the peripheral perineural invasion. So what is the characteristic? There are other few characteristic features that you see with prostatic carcinoma. One is a perineural invasion. So you see, you can identify this is the nerve here. So if it is circumferentially, you know, circumferentially, it is surrounded by the malignant neoplastic gland, prostatic gland, it is known as perineural invasion. Now, just a gland indenting into the nerve does not make it a perineural invasion, because that is, you know, commonly seen even with benign lesions and even in benign tissue. So just indentation into the nerve does not make it a perineural invasion. To call it a perineural invasion, it should be circumferential engulfment of the neuron, basically, nerve bundle. Okay. So presence of prostatic glands within the perineural lymphatic spaces, path of least resistance and predictor of capsular invasion. So this again on a section, on a biopsy, it's very important to mention this. It's a core data element that you have to mention whether you found perineural invasion or not. Then there is another characteristic finding, and these what we are finding basically now is that these are pathognomonic sort of malignancy. So perineural invasion, pathognomonic of malignancy. Mucinous fibroplasia or collagenous spherulosis, again pathognomonic of malignancy. The stroma surrounding the neoplastic gland shows a combination of hypercellularity and deposition of basophilic ground substance. So just look at this here. So these are the neoplastic glands, and these neoplastic glands are surrounded by these this basophilic ground substance. Ground substance, the basement membrane-like substance is there in the surrounding. And if you see something like this, this is never seen in a benign tissue. Obviously, very difficult to catch on for early, you know, young pathologists. But still, if you have an eye for it, just look for malignant glands, and surround in the surrounding areas of the malignant gland. If you see this kind of basophilic ground substance, which is you know, hypercellular and you know, sort of just acellular substance present, it is mucinous fibroplasia. So then again, there are protein crystalloids which are different from the you know, the bodies, the secretions that we usually see is the protein crystalloids. These are you know, geometric shapes. They're not round, they're not of any shape. They're basically geometrically shaped clusters of the secretions, and they're usually present in the medium-sized glands, usually seen in recent pattern 3 or 4. And so those are also not really pathognomonic, but yes, characteristic of these glands. neoplastic glands. Now, wispy blue mucin in the lumen of malignant glands. Again, this is wispy blue mucin. I mean, you cannot really, unless you see neoplastic glands and then you see mucin in it and you call it a wispy blue mucin, all right. But just based on wispy blue mucin, you cannot diagnose malignancy. The presence of corpora malacia is not necessarily a sign of benignity, as previously believed, especially in well-differentiated prostatic carcinoma. So this is the point that I made even in the beginning of the class, that corpora malacia is not a sign of benignity completely. All right, so majority of the benign glands will show corpora malacia, but in well-differentiated adenocarcinomas, you still may see corpora malacia. All right. So we'll be doing other variations of prostate carcinomas, and we'll be doing PIN and some more questions tomorrow at 7:30 p.m. Any questions for now? All right. Okay, fine then. I'll see you guys tomorrow. Good night. Bye-bye.
Bye-bye, ma'am.